Okay, how to start? Which one? But what matters is what's shown here. You have to put the shared one.
Yes, yes.
This one? This one?
Yes.
Oh, good now? Yeah, it's okay. Okay, Bismillah ar-Rahman ar-Rahim. I think we'll get started. Thank you all for coming to this webinar today about NASAM. And we have excellent attendance here in King Abdulaziz Medical City, and we have good attendance on the webinar. This webinar is meant to be open discussion, so we want people to share their thoughts and ideas and suggestions on how to make improvement. And as in the flyer that we put, that this is the old idea of this webinar is to how to use the data of your unit to improve the care of mechanically ventilated patients. So the slide summarizes where we stand in all the hospitals together. So we have now data about certain indicators for mechanically ventilated patients on like 20,000 patients. So the average, national average for using subglottic suctioning is 27%. It's 27%. So we're going to talk about this in more depth. Spontaneous awakening trial is an average 51%. So about 50% of who are eligible to have sedation interruption are getting it, only 50%. Sedation, patient ventilated without sedation, around 40%, and the rest are sedated. Spontaneous breathing trials are done in 54% of patients who are eligible to have spontaneous breathing trial. Percentage of patients who have RAS between -1 to 1, in other words, awake or slightly sedated, are 35%. So the rest of the patients who are ventilated are getting heavier level of sedation, which is probably high. Achieving the RAS target is 27%. So typically we want patient, for example, awake, but often patients are more sedated. And I think that's probably not surprising to many of us. This is actually the case. Percentage of patients who achieved weight bearing, who are ventilated, is about 0.5%. So the patients who are ventilated and can stand or more, 0.5%. It's very low. Non-ventilated patients who are achieved weight bearing, standing and above, is 14%. So that's overall where we stand now. So I think a few things to make a difference at the unit level is that we need to make sure that each unit has a team that looks at own data, and use it to make a difference, use it to improve. And without this, it will not change. And I'm going to show you in the following slides examples of units that clearly making difference, and units that are not making big difference. And if you look deeply, what are the main reasons why some units are making difference and some units are not making difference is it's related to the people who are in the unit, really. There are people who are committed to make a change, a cusp team working together and looking at the data and making difference. And the units that haven't done this yet, the number is still flat. This is a data-driven project, and we're hoping that by looking at the data, for example, today, we can get some insights on how to use it to guide our change. So what I thought I'll do, and again, this is not supposed to be a lecture, it's supposed to be an open discussion. We selected few examples for each indicator. So selected a good example, average example, and not so good example. So this way it helped us to think mentally, contrast these ones, and see that where we stand. So you understand the whole idea of benchmarking. So for example, the spontaneous, the subglottic suctioning compliance, and these are all units participating in NASAM. So these are real units. Yeah, I have a question.
the majority of the patients have take this trade already without subglottic.
Yeah.
That's why our rate was all low.
Yeah.
At that time, we have 4 patients with trade.
Yeah.
4 of them is not with subglottic.
Yes.
So I took even to Shana. She said it's very rare we have this shiny with subglottic.
Yeah.
And we don't know really what we can improve with this one. Even
Yeah.
she said it's trade have something in the audit different than ETT.
Yeah.
Because our ETT, all of them was subglottic. But the trade is the one making our compliance slow.
Right.
How we can fix it?
Yeah. So let's talk about this. We'll talk about when we talk about the suggestions. So this is an example of one of the ICUs, and really, I really like to thank them. They made a big difference. Started with 17%, and once they recognized it, they went up to almost 80%. It's been stable. Okay, so they want a clear, big improvement. So the blue line here you see is your unit. So if you log in, this is your unit, the blue line, and the orange line is the national average. So national average, we are like 25 to 30%, as I said. So maybe a few explanations here. The number are slightly, you could see it's slightly coming down. It's not really coming down. So you think that it's coming down, but it's not necessarily this true. It's because more units are joining. And the new units, many of them don't have subglottic suction, so it brings the average down. But anyway, more recently, I'm hoping that in January now it start to go up. Okay. So this is an example that we really like to see in all the graphs to see this type of improvement. So this is another unit where the numbers are above the average, slightly above the average, but they are kind of status quo, no change. There's no change. And we like to see this different. Now just explanation, the blue. So in this unit, there is one ICU in that hospital participating. So there is a blue, and actually there's a green on top of it. Because it's one unit, they're identical. You can see it, but that's what it is. And if it's part of a health system, which is not the case here, it will look as a gray. So for example, in that hospital, there's a green and blue on top of each other. And there is the health system, which is gray. So let's say health system meaning National Guard hospital together, or military hospital together, or MOH together. So it's give you idea comparison of your own system. And the orange is everybody. And lastly, this last unit, it's 0%. So basically, they don't have it. It's bottom line. This is what why it is. So in this unit, subglottic suctioning wasn't available and still not available. So it's 0%. So when we look at this data, I think it will help really to put things in perspective, right? To understand, yeah, there are certain people who are doing really great job in putting this up, and I think there's big room for improvement. So we know that Ministry of Health now made it available for subglottic suction in all hospitals. It's a matter of using them or getting them to their units, I think. So some thoughts which we discussed before. So our target, where do you want? Do you want it 100%? Maybe that's not achievable. So not achievable because you have, as Zainab just mentioned, there are patients who have tracheostomies without subglottic suction, surgical tracheostomies. Can't do anything about this. You have patients coming from other hospitals with endotracheal tubes, and you really don't want to change the tube. That's no point. So there are some patients, and there are some patients come from OR and not completely in your hands. So there will be some room for allowing this not to be 100%. Would be ideal to be 100%, but may not be feasible. And I think the limiting factor is that these tubes are more expensive. These subglottic tubes are more expensive than the regular tubes. So you cannot just say, let's use them for everybody. It would be big waste. So what we thought that, and that's what we are doing in many ICUs, making sure that these tubes are available in the unit. So a patient inside the unit needs to be intubated, use subglottic septic tubes. That's what we are using, right?
Yes.
Yeah. On crash carts in the hospital, the whole hospital, we're using subglottic tubes. And emergency room,
Yes.
we are making this available in emergency room. In the OR, I think it's a little more difficult because then you'll be wasting a lot of tubes. So we said maybe we don't need to necessarily. They have it? Yeah, if you have a mechanism to make sure that they do it for patient coming to ICU, would be fantastic. So maybe we'll open it for thoughts or discussions about this. Please use the microphone. And also for other sites, you can, if you have a comment, you can send it and we can unmute your microphone.
The subglottic suction compliance itself. We already seen that the use of subglottic tubes with subglottic suction is there or not. So once it is known that we are using the tube or not for the suctioning part, why not exclude the patients who are not having subglottic suctioning port? So you get exactly.
Say.
I mean, tracheostomy without a subglottic suction port.
Yeah.
Exclude them from counting for the suctioning compliance.
Yeah, we can. Yeah, we can generate data separately for intratracheal tubes and tracheostomies. Yeah, we can do that easily. But and the way, at this stage, it will be hard to change these indicators, but easily can be done. But I don't think it's necessary.
I mean, if you have a proper compliance, then.
But we want also
availability will not be part of the compliance.
Yeah. Well, the idea is not necessarily to get 100%, and doesn't mean that if you're 60% and that because you have a lot of patients who have tracheostomies or chronic patients, and I think that's okay. I mean, some of the differences maybe relate to the type of patients you have, and that's quite acceptable. All these indicators, we're not expecting everybody going to be same. It's going to be impossible to be all the same because you have different patients. It's not going to be the same. So allowing for some differences, I think is acceptable. But I thought what you are also bringing the issue of making sure that the patients who have endotracheal tube suctioning are connected to the suctioning properly, right? That you are using suctioning properly for what it's meant.
So the recommendation is continuous suction.
Right. And yes, internal suctioning, and we have a protocol. Can we share? Did we put it on the website? Can we put this? Can we put the protocol on the website of the subglottic suctioning? So let's put that on the website so everybody can use it. Any comments from other sites? Yeah. So next is spontaneous awakening trial. So there is a question from Ali Hassan. Can you unmute? تفضل دكتور علي أو مستر علي. Hello. Hello.
Yes, you are hearing me.
Yes, تفضل.
Assalamu alaikum.
Assalamu alaikum.
I'm asking about subglottic suctioning. Do we need a special machine to connect that subglottic machine continuously, or we can just use the normal suction machine?
So I'm going to ask one of our RTs to answer. What's the procedure?
The normal machine for the regular suction, we can put it on the intermediate suction.
At what level?
At 20.
Minus 20.
Minus 20 centimeter water.
Intermittent.
Intermittent.
Yes. So no special machine. We'll put the protocol. We'll put the protocol on the website so people can use it. We've been using subglottic suction now for years. So I think it's very useful. Very good. So let's talk about the awakening trial. And here we really appreciate the nurses' help. Can you see or not? It's not moving. Okay. So here's one unit. So spontaneous awakening trial, which means sedation interruption. So this is one unit that showed big improvement in SATs from 60% to almost 100% of the patients who are eligible to have spontaneous awakening trial. Okay, the average is shown in the national average is shown in the orange. The green is for that hospital, and you could see. So this is one unit among several hospitals, and you could see the green also has gone up. So the whole hospital has gone up, but this unit in particular has gone up faster, and the health system, and so this much collection of multiple hospitals also has gone up a little bit. You contrast this with another unit where the numbers didn't change much. In fact, they are lower than the national average for some reason. So they are low, but they remain the same. Okay, no much change. Now in quality, when you have multiple, so this is it's called stable process. So you look at the orange, there's no change, right, Hamad? So it's a stable process, 5 points. If there are 5 points, they are within the about the same, then this is a stable process. Versus the blue one on the left, looks like there is a change, correct? A third unit here, I mean, the data is showing 0. I don't know, but this is the data showing 0% of patients have spontaneous awakening trial. So none of the patients who is eligible to have spontaneous awakening trial for this data is having spontaneous awakening trial. So 2 issues when we are doing this project that's coming up. One of them, we have to make sure that people are understanding what the data they're entering, to make sure it's actually recording the correct data. So spontaneous awakening trial, meaning the patient sedation has stopped. No, so that's yes. No, meaning the patient could have it done, but it's not done. And contraindicated, meaning the patient medically cannot have it. There is a reason for the patient not to have it. Because if the patient, for example, severe ARDS on sedation, this is contraindicated. You should log it as contraindicated, not no. If you put it as no, it will be non-compliance. So these are 3 examples, maybe extreme examples, but that's what it meant, to give you different examples of change in practice for spontaneous awakening trial. Certainly, we don't want to be 0. I mean, this is really low. This is not good. If this is true, we want to pull this up. So patients, I mean, the standard of care, sedation should be interrupted every day. And I think I would really appreciate this unit to start to work on it to make a difference. Any thoughts from nurses before I show my slide, or from anybody? And also from the audience, other hospitals.
Is there understanding possibly of the awakening trial? The patient didn't wake up.
Can you use the microphone?
The understanding of the data collector for the awakening trial. If they think the patient didn't wake up, is not included. Is there a problem in data collection?
Okay. So could it be a problem? People didn't understand what's awakening, spontaneous awakening trial. Spontaneous awakening trial means sedation vacation. So there are multiple terms for the same thing: sedation vacation, sedation interruption, sedation, spontaneous awakening. They're same, meaning that you stopped sedation, all sedation, all of it, regardless whether the patient wake up or not. I mean, this is not regardless of the patient waking up or not. So, can you give the microphone?
If we try, but we never, like a few minutes, consider that we did the trial. Like a few patients, if we just off it and within few minutes he already agitated or he started or whatever, and then he resumed.
What's the answer? Great question. Yes, the answer is yes. So the answer is yes. Same for spontaneous breathing trial. You put the patient in trial and the patient was apneic or was tachypneic, then it's yes.
But it will not count unless if you have the data. Will not
Of course.
count that you tried unless if you put the data.
Yes. So you have to document that actually you did spontaneous breathing trial, whether that's on your electronic medical record or in this project. Otherwise, we would never know. But that's a great question. So any thoughts so how to for units to make things better? What would you advise for a unit that is not making difference, no change?
If we also consider avoiding vaso, because it's sometimes affecting the waking time, we will give the patient chance he will never wake up to that. This is also sedation used, it's also make difference, and how we wean it gradually to prepare for the waking trial. If he didn't start already to wean it gradually, we'll never success with the trial. It will patient heavily sedated already.
Yeah.
I think we need to work in this one to really encourage the nurses to wean the sedation, not to keep everything at maximum without any reason. Patient already GCS3 and we find 2-3 sedation on the high dose. So this one will improve our trial. So it will be successful more. We'll not go for apnea and will have effect from the trial.
Excellent. Any other suggestions?
As we discussed
Okay,
last
microphone.
As it was discussed last time, we just to stick to the protocol.
Yeah.
To stop the sedations at 7 a.m. and stop doing the meetings and just stop the sedations. I think it's going to be a good input.
So you are suggesting for units that don't have it, for example, this one has very low, to use protocol, and your protocol you are using, you're stopping sedation 7 o'clock in the morning. Yes? So this is a great point, sedation, having a protocol for sedation vacation. Also not using benzodiazepine is a great point. And readjusting the sedation based on the sedation level, right? Assess the patient's sedation and adjust sedation. So no point if somebody is deeply comatose to keep him on 3 heavy sedatives. So what do we want? We really want this to reach 80% and above. It is the most important part of the whole project, sedation, I think. Okay, next, spontaneous breathing trial, which is closely related, very closely related. So this is an example of a unit that really has made a difference, almost double, more than double. It's reached 95, 90%, which is remarkable. This is what we want. So patients who are eligible to have spontaneous breathing trial are getting spontaneous breathing trial. This is another unit which still around 50%. And it's actually, for most part, it is lower than the national average. With the exception last month, or this month actually, start to go up, which is good. We like to see that, right? I'm make sure this is real. And we need to make sure that we're actually correct. But this, for the first month, this is going up above the average. And this is the third unit, which is probably similar, same other unit. No spontaneous breathing trials at all, which I find is surprising. I mean, how could you wean patient then? So again, we need to make sure that they are actually understanding what is that. We really need to have a teleconference with these units, make sure that we are understanding the data correctly and entering the correct ones. And if it is the case, I don't know, it's possible, then we have to make an action. We try to help implementing protocols for this. And we put on the website some spontaneous breathing trial protocols. So we want to enable the RTs, but the problem is some ICUs don't have RTs. Or whoever managing the ventilator to have a protocol for weaning patients for spontaneous breathing trial. and the target is 80% and above. Spontaneous breathing trials with sedation off. So this is a unit that is, so the average is around 80%, which is actually not bad. So we're doing a lot of it without sedation. These are a few examples. I don't know why this unit is going down, so it's going up. So we say lots of variations among different units. So it will be interesting to see what's this unit. I think we should look at your data and see why things are changing in one direction or the other. I don't know. So the practice getting worse. So they are spontaneous breathing trial with sedation off is less often. The target is 80%. So what we need is really, first, I think the choice of sedative is very important. What you just said, Zainab, is very important. Avoid benzodiazepine, which is by guidelines is second line, not first line. Also avoid high-dose fentanyl, because it's probably the same type of side effects. Also, intentional rounding is that in many of our units, anybody want to talk about this? Salha, you want to talk about this? What do we mean by this? Intentional rounding.
We start this one surgical ICU round in the morning.
Use the microphone.
We start the round in the morning after the endorsement that we tell the nurses to stop the sedation.
That is the nurse manager.
The nurse manager.
Yeah, the nurse manager. So the nurse manager goes over all the patients in that unit, correct?
And we ask the nurses to stop the sedation.
Yeah.
At every morning, and then to inform the RT team that the sedation is off, so they can work together and stop and changing the ventilator.
I think if we do this, then all units will make a huge difference. RT's leader, team leader is also doing similar.
I mean, they are not doing it around the nursing situation.
Yeah.
But usually we do some sedation.
It would be worthwhile to do this. And so it's hand over.
Every morning we endorse patients at bedside.
Yes.
I think it would be legitimate if we follow the same practice like nursing.
Yeah.
As we endorse, we start by every patient based on the endorsement of the nursing, and we go accordingly. I think this will reflect on the finding.
I think if you do this, it will go up to 100%. Honestly, I think it will go up to 100%. And if you are doing handover already, just add this to the handover. One of the checkpoints. Just check it out. For patients. Yeah.
We exclude the issues for
No. Don't separate.
Maybe it would be very useful to separate those.
Well, I think it's bottom line is we're not doing it for the sake of the numbers, really. We're doing it for the patient. So if you want to make an improvement, you're going to make, if this is one of, God forbid, one of your relatives, what you want is to have coordinated SAT and SPT. We need, this is what the best practice is, that we coordinate them. So we plan it. We want to stop sedation and do the SPT. But if we do it, nurses do it alone and the RT do it alone, because everybody is busy, if they're not synchronized, it will be less effective. Because she stops sedation, the patient becomes agitated, return sedation. By the time the RT comes, we find the patient active. This happens. So if we coordinate them, and probably if you do the handover, it will be almost automatically coordinated because they are going to happen at the same time. Yes? So this is not. So I think what we think we should do is each unit should have a protocol for spontaneous breathing trial. And we have on the website a few examples. And also intention rounding by the manager or the CUSP team or the NASAM team or designated person. And it will take, or CRN, it will take a few minutes really to check this out. Salha, microphone, and then Dr. Hassan.
Just to share this one, I think if the nurses also know how to control the pain before they stop and return the medications, the sedation, that would be a good point. Because when we stop the sedations, patients become agitated, they return, but they don't never think about the pain. So if they treat the pain also, it will help, because this is what happened for us for the last 5 days. We tried this, and then within this 5 days, around 7 to 8 admissions. We received them and intubated. We discharged them within 2-3 days. So that's working also with us.
Oh, that's fantastic. This is great. So I think what Salha is saying, if you have a patient who looks agitated, should assess for pain. But I think which is very, very important, and you should assess for all other reasons of agitation. So the treatment of agitation not automatically gives sedatives. Some of the old people are agitated because they are constipated. Some of them some people don't sleep on their back. I mean, people forget this. If they have back pain or they don't sleep on their back, and you keep them on their back, they become agitated. We have cases, I think RTs know this, patient is agitated because of the endotracheal tube, actually. So sedating him is not a solution. Actually, it's, you're making things worse. So we should consider the reason why the patient is agitated. Dr. Hassan?
From our observation is that there is misunderstanding of the definitions of these terms.
Yeah.
And this is why nurses sometimes are not entering the right information.
Right.
So when a patient is contraindicated to have these interventions, instead of saying contraindication and contraindicated, they are saying no.
Yeah.
And one of the things I'm thinking about, what could it be that nurses are not familiar with these terms, and so it may be reasonable to make them part of the daily communication. Like, for example, I'm not sure about this, but maybe I use spontaneous breathing trial, or I say it SBT. Maybe our respiratory therapist will say spontaneous breathing trial and SBT, but I'm not sure if nurses use this term.
Yes.
All of you?
Yes.
I'm just.
But I think the point is very valid.
If we use this term frequently and understand it, because when we now take the data collection form, now we understand. Frequently, I say Glasgow scale, and people do not know what's the Glasgow scale. They know GCS. They don't know what's Glasgow scale. So this is just.
So, but the Dr. Hassan is raising a very valid point, is that he observed, and I think this is definitely exists, that some patients were labeled as no when they were actually contraindicated. And we need to get the data right so it reflects the truth. So I think it's worthwhile that we spread this just to educate people about what's yes mean. So yes, what Zainab mentioned, stopping sedation even for a few minutes. This is called sedation. This is AT. No meaning that the patient has no contraindication. He has no head injury, no severe ARDS. He's not on neuromuscular blockers, but not done because, I don't know, just kept him on sedation. And the third contraindicated is ARDS, head injury, neuromuscular blockers. Yeah? Okay, we have a comment? Yeah.
I have comments for the previous slide.
Previous slide.
Yeah, so what this one? The spontaneous breathing trial with sedation off. This, I think sometimes this one very hard to improve the compliance because some patients already, when she's not in sedation, they are chronic already, like chronic but we are not doing for them trial anymore because they might already not need it. Some of them, they are not waking up without sedation. That's why we are not using sedation.
Correct.
That's why also we cannot do the weaning trial for them.
Yeah.
Because those GCS, we will not do continuous trial for them.
Yeah.
When the GCS is very low. How we can improve this one? Because I can see really sometimes it depends on the patient condition.
Correct. So you're going to have some patients who are chronically ventilated or some patients who are just not weanable. I mean, they exist in most units. and that's probably going to bring your numbers below 100%. But I think we have to. That's what it is. I mean, I hope it's not 100% of the patients, but
when they are off sedation, they are majority.
when they are off sedation, they are majority.
If the regular patient who can wake up, we usually give him small dose sedation to control his during ventilation, and when we need, we will successfully. But this type of patient from our unit, when we see this type of patient who is ventilated, and he is not in any sedation, this type of patient who is really low GCS without any sedation, we're waiting for them to wake up. We do CT brain to rule out any other underlying cause why he's not waking up. This kind of patient, we're really not doing for them much sedation. We're winning the trial.
Yes. So I think there are 2 points here. This is the idea of benchmarking, okay? So you are benchmarking to other ICUs, average ICUs. So we are similar to other ICUs, and probably some of the problems you have do exist in most ICUs, more or less. That's number one. In these quality improvement projects, we have to strike a balance between simplicity. If I make a lot of definitions, do this if the patient chronic ventilation, don't do this if you know, don't enter. It becomes so complicated that becomes a nightmare. Already, I mean, we're having difficulty of people understanding what SBT and SAT means. Yeah. So if I put a lot of conditions, it becomes really hard. I think we'll make more mistakes, I think. So you have to make it kind of simple and accept that the numbers may not be 100%, but that's why the idea of benchmarking. So the idea of benchmark comparing to the others is where, so it's you are gauging to the others, right? You're comparing to the others anyway.
How do we address this patient? Let's say you have a patient who is comatose, on ventilator, off sedation. What would you?
He's off sedation.
Should be yes. What are we answering for that patient?
It's a we make trial when patient no sedation. He has
There is sedation, yes or no? Right? Yeah. So there's a question: is sedation yes or no? So if it's no, it will be no sedation.
Yes. This continuous trial for those patients.
Breathing trial is a separate question. So he will not have. So this patient, chronic ventilated, not sedation, will be sedation off, and the question of SAT will be irrelevant because he's not on sedation aslan. Okay. SBT, he has no SBT, not done. No, it will not disappear. SBT will not disappear. Okay, next action. So we talk about this. Neuromuscular blockers, I think this is just the guide. I mean, because, so this is an ICU. The numbers are relatively small. Sorry. So this one ICU that showed reduction in use of neuromuscular blockers. I'm not going to generalize too much on this because the numbers are really relatively small. And I think when we have bigger number of patients, we can tell more. But we are hoping that generally it's used less than 10%. Now, okay, mobility. Weight bearing, which means standing or more, for patients who are ventilated. The national average is about maybe, actually it's going up slightly, from 0.5 to 1%. 1.8%. So has shown some increment. This unit 0 was higher than it went to 0. It remains zeros. And we'd like to see some patients at least who are mobilized, standing and more. I mean, there are some young patients who are previously baseline is good. On the other hand, the contrast, this is another unit that took the opposite direction completely. It's really taking off. So surgical ICU. So really taking off, and you could see clearly this is going up, which is excellent. We put target 10%. Maybe that's an overstretched target. But it's really nice to see 10%. But I would like to see some improvement. In patients who are not ventilated, so these patients are not on the ventilator, not on the ventilator. So I have a patient who post-op extubated, is not ventilated today. You like to see some of these patients walking, going to the bathroom. Right? Many of them are healthy. So the numbers here is around 50% average. This unit, for example, is lower, much lower. This unit really start to make some improvement. But again, something to keep eye on to improve. We like to see mobility. We're not seeing a lot of mobility. We'll hope for 40% at least. So early mobility involvement, nurse-initiated mobility protocol, we try to implement in our hospital. Also, what we need help in all is to look at the VE and collect the data. I'm not going to make big conclusions based on these graphs because they are not from many units. But so this is a unit that is showing VE going up. This unit is showing VE going down. But again, this data, some of it still need work and validation, and maybe not complete. Also, we're going to be looking at whether mortality is going to change or not. But we need people to put the data so to make some sense out of this. So I'm going to conclude a few slides because we have 2 presentations. So we are updating the resource page, and we welcome people submitting their protocols if they want or resources. You could see here we put resources to the link to the SCCM website. We put an SBT protocol. We put a weaning protocol. We would like to add the subglottic suctioning protocol, if we can do that, Ahmed. So this is a data completion for all ICUs. Each line is 1 unit. Green, you have data, these weeks. Red, no data. So some units are participating continuously very well. Some units are halfway. Some are not contributing at all. And we like to see this is improving. We like to see more green, less red. Early mobility. Early mobility again. Some units did not contribute, and some contributed good amount and were consistent. VE and objective outcome measures. These are the first 3 months. So we should have all this data completed by now. But as you see, it's probably 50-50. We'd like to see more so we can make a judgment whether there is change or not. So we really welcome and we encourage everybody to contribute data. Any questions, or we can move to the next presentation? Can we move to Dr. Hind? Let's see. Which one? Dr. Hind. Dr. Hind. Dr. Hind. Saw the presentation?
Hello.
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 Yes.
Can you hear me? This is Fusia from King Faisal Specialist Hospital and Research Center. Dr. Hind is quite busy today, so I'm going to give the presentation.
Okay. Or you want to wait?
Do you have my slides, doctor?
Yes, I think so. How can you share?
It's okay, this is hers.
Okay. Which one? This one.
Yes.
Why is not showing here? Can you see the slide now?
Yeah. Here it's showing.
Why is not showing here? No, it has not. No. Setting. Yeah. Go ahead, please.
Okay. Good afternoon, everybody. This is Yal Khaldi from King Faisal Specialist Hospital and Research Center. I'm a bedside nurse, part of the NASAM committee at King Faisal. I'm going to talk about our experience at King Faisal Specialist Hospital. We participate with 3 intensive care units, as you know, with total of 40. We are more 170 nurses, 10 RTs, and 3 BTs work in this unit, and we are all from different cultures and background. The first issue we faced, the manpower was the hardest part to handle. We were overwhelmed thinking how we are going to make different teams work together. So we formulate this NASAM committee. We assign a team leader who can communicate and foster the process. We utilize all the communication that we have in our mobile to carry out all the plans. Before that, I think it's a smart idea from our ICU, the frontline people, to attend the NASAM workshop 2 days at National Guard. So back to our unit, we start to empower our frontline practitioner. We educate, we send emails, and we had a group discussion prior to the data collection. January, we started to collect our data. As you can see in this graph, if you can move the slide, please. Initially, I was the person who is entering the data into the system directly without using any paper, but other units called the ICU chairman, and they were complaining there is no staff and other tasks that we have to do it as a nurses. So he assigned the research coordinator to enter all the data. But before that, we have to formulate the paper, which is easy and applicable for all the nurses to fill. And we noticed in February, our delirium assessment utilization rate dropped down from 100% to 84%. And the percentage of actual RAS from -1 to 1 dropped from 25 to 0, which is not possible because we use RAS in our hospital. Mm-hmm. I mean, this is our policy. But we called for a meeting, brainstorm, and root cause analysis as well. So we found out that we were given 3 options to use RAS or SAS or not use. So we misunderstood the question, and we thought if we are going to use Glasgow Coma scale for our patients who are not sedated, means we are not going to use RAS. So we selected not use for all the patients. But when we review the patient charts, our patients in that period were RAS -1 or 0. So we misunderstood this question before. Mm-hmm. So Dr. Ali and Dr. Hind work in this form, and they modified for us, and they eliminate all the options. They kept us with RAS only. And it helps to improve our data, actually, if you can see our graph. Mm. And for the comatose patient, this was my question and my team question as well, because we thought for the comatose patient, we are going to use Glasgow Coma scale, so we are not using RAS at all. But I contacted you, I asked you directly, and you recommended us to use RAS even for the vented patients who are not sedated or they did not receive sedation at all. And for the spontaneous breathing trial, they make it very clear for us, and they added clear information that if the patient in pressure support would be of equal to 8 or in TPs, we have to consider it as a spontaneous breathing trial in regards to patient pass or not, but we have to consider it as a spontaneous breathing trial done for this patient. First 3 months, we were doing the early mobility for the vented patient only. Then they called for another meeting and they said they want the data for both vented and non-vented patients. Again, we reviewed our data in March. So we found our spontaneous breathing trial compliance rate dropped from 100% to 75%. So we were looking for the possible causes. So there is lots of contributing factor because we had the newcomer nurses who are not familiar where to find the protocol. Actually, we have all the protocols in the system, but the new staff were not able to find these protocols, and some staff said it's not easy for them to find it because it's scattered everywhere in the system. So we called for a meeting. We plan to have a new improvement project in our unit. We call it ABCDF bundle, implementation of ABCDF bundle into daily patient care. Moving to the early mobility, Dr. Yassin, people are not comfortable to mobilize patients with endotracheal tube. So in the paper, there is a question, what is the barrier to achieve the higher level of mobility? Most of my nurses answer this question because patient is intubated. We don't have this option, but they write it down for us, patient is intubated. And as a nurse, we try all the time to protect our patient, and we don't want to harm them. So we keep them in the bed while there is no contraindication really to mobilize this patient out of the bed. And NASAM data really helped us to start a new performance project, as I have said before, to implement the ABCDF bundle to be easy, accessible, feasible for all the practitioners and the system. And in the near future, inshallah, we are going to share with you our results after implementing this project.
Excellent. That's fantastic. This is great achievement. Excellent work. And you always come with the right questions. Clearly, these forms are really, really matured. So if you don't mind, you can, if you're okay to share them with the group, we can put them on the website so other units who might want to use them can use them, if that's okay with the team. Any questions? Yeah. So you could check with your team if they're okay.
Yeah.
You can put them. So one great question was raised before, and no clear answer for it, which is, should you use sedation scores for patients who are not on sedation or who are comatose? And I ask our nurses, and basically we do it for all patients every 4 hours. Now, I also looked at the literature, and so I send you an article of using this. The answer is probably not black and white on this one, right? It could be a gray. But as long as in the same project we are using one approach. And since we said we're going to use it for all patients, we better use it for all the patients. But if one place use it only for patients on sedation and patients, another place use it on patients, everybody, then we'll have a lot of apples and oranges. So that's why I told you we'll use it on everybody. Regarding the mobility for non-intubated patients, so you mentioned that you did not collect on this, and that's okay, because it doesn't enter in any, it's a separate calculation anyway. It's for the calculating for patients who are not ventilated. So it will start to calculate for you from the time you enter data for this. It will not affect anything else, not at all. So not an issue. But this is an area, and I really, when on rounds, see a patient who's not intubated, who's actually ready to go to the ward, maybe waiting for a bed, but he's still in the bed. And he wants to go to the bathroom, but no, you bring him urinal, you know. We want these patients to be mobilized. These patients should be mobilized. Many of them, their baseline is okay, and they are mobile. To keep them in the bed, so the paradox here, this patient will go to the ward And on the ward, he will start to walk immediately while he's in the ICU in the bed all the time. So, and I think we need to change. The point you raised about the nurses saying the contraindication for mobility is being intubated is exactly what we are trying to change. That intubation by itself and being on the ventilation is not contraindication for mobility. You've probably all seen pictures, and we already seen videos actually from several MOH hospitals in the NASAM project. I cannot share them because of confidentiality, but patients walking with endotracheal tube, okay, in small, not in medium-sized hospitals, let's put it this way, okay? They are really, really doing a great job. We know that patient can be mobilized even on ECMO, right? So let alone being intubated.
Yeah, true.
That's easy. Yeah. So ECMO patients.
Yeah, it's just culture, Dr. Yassin.
So culture, really we need to keep working on the culture. So lots of this project is about culture. And what you are doing is you have a team, you are meeting with people. This is really what you are, and trying to use the data to drive a change. So you're using ABCD protocol and creating some local protocols that fit you. Probably doesn't, in other places they want to do it differently, but that's exactly what's the idea. You are the only one who can make a change in your unit. You are the only one because you understand it, but the data hopefully can stimulate some, trigger some thoughts. Well, this is great. I really congratulate you on this, and fantastic. I'm looking forward to see improvement in the data and hopefully in patient outcomes as well. We're supposed to have another presentation, but the time is, I think it's 3 o'clock already. So if it's okay with, who's supposed to? Mr. Ali, if Mr. Ali is okay to postpone this to next time, I think very good to have this type of presentation to hear what units are doing. And there is nothing wrong. I mean, our units, not all of them are going up, okay? So we're looking at the graphs to make a change. We're not looking here at to critique. That's not the point. We're trying to learn how we are doing business. We're all good people trying to make things better. So by seeing graph that is below or low or high or going down or up, this really doesn't, it means that we are looking critically at our data to make a change. As long as we take it this with this concept, I think we'll be fine. Okay, very good. With this, I think we'll conclude, so we'll not keep people holding. We're going to post this on, we'll post the video on the website, and some of the material that we will put it also on the website, the subglottic tube. And if King Faisal are willing to share this, if they want to do it with the logo, without the logo, it's up to them completely. It will be nice to, it will help other units as well. Thank you very much.